I've been fortunate to be involved with a number of studies that have initially suggested that aspirin reduces the risk of developing colorectal polyps or cancer. And after our initial observational studies, randomized trials have shown that individuals randomized to aspirin are less likely to develop recurrent polyps. So I think level 1 evidence for aspirin as a preventive agent. But more recently, we've decided to look and see whether aspirin has a benefit for patients with established colorectal cancer. That is, can it be an adjunct to standard therapies? So we conducted several studies in which we collected information on aspirin use among patients who started chemotherapy for stage 1, 2, or 3 colorectal cancer. And in all of our observational studies, those individuals who reported aspirin use had significant improvements in cancer-free survival. So we certainly, at least based on observational data, it does appear that aspirin works. Moreover, we tried to sort of understand mechanisms and define biomarkers. We think that one of the targets for aspirin is cyclooxygenase 2, or COX-2, a marker which clearly does affect an increased proliferation in cancer cells, and moreover, about 2/3 of colon cancers overexpress COX-2, the presumed target of aspirin. So we then asked the question, well, if aspirin works in our cohorts, is it yet more effective if the patient's tumor overexpresses COX-2? So in our laboratory, we measured COX-2 in all the tumors by immunohistochemistry, and what we've in fact found was that the 2/3 of patients where COX-2 is overexpressed have a significant improvement in survival, whereas if their tumors did not overexpress COX-2, the benefit of aspirin was really minimal. So an interesting potential biomarker that would suggest what 2/3 of patients most ought to consider aspirin in conjunction with their chemotherapy. Finally, we've done some additional studies, most recently looking at the genetics of colon cancers. And what we also find is that patients whose tumors have a mutation in the PI3K pathway, that is PIK3CA, if they have a PIK3CA mutation, there actually is a profound benefit of having aspirin as part of their therapy. So it suggests potentially a number of markers that could identify patients who would most benefit from aspirin. Now, these are all observational studies. Clearly, what's needed are randomized trials, and an ongoing trial is going to look at this question, namely CLGB 80702 is an NCI cooperative group study in which patients who have been resected for stage 3 colon cancer are all receiving FOLFOX chemotherapy and are being concurrently randomized to celecoxib or placebo. Not aspirin, but a COX-2 inhibitor that is certainly legitimate, and to really ask the question of whether COX-2 inhibition, akin to our observational studies, in a phase 3 study can contribute to survival.